Good morning, good afternoon, and good evening, everybody. Thank you so much for joining us for this, our second webinar in the Conversations in Virtual Care series. For those of you who are new to the IHF Virtual Care Special Interest Group, the Special Interest Group serves as a platform for IHF members to share information, share knowledge, share best practices, and learn from each other across the globe in terms of how virtual care is managed in each setting. So we are very pleased to be working in collaboration with Apollo Hospitals Group in terms of sponsoring the virtual care special interest group. And our host for this meeting, Dr. Sai Praveen Haranath, has been instrumental in setting up the group. In the meantime, it would be great if I could just introduce quickly our panelists. So can I come to you, Rob, just to give a one-liner of who you are and where you're from, and then we'll come to Sigbjorn and Anis. Thank you.
Thanks, Ilona. Robert Marshall is my name. I'm the Chief Strategy Officer at St Vincent's, which is a large non-profit healthcare organisation in Australia with public and private hospitals and an aged care portfolio as well as virtual and home-based care. And I'm the Chief Strategy Officer there.
Yes, Sigbjørn Smeland. I'm head of the Division of Cancer Medicine and also the director of the CCC board at Oslo University Hospital in Oslo, Norway.
Hello, I am Anis, head of IT at Indonesian Hospital Association or PERSI, and also a researcher on digital health at Universitas Gadjah Mada, Indonesia. Thank you, Ilona.
Thank you so much to our panelists. We're all thrilled to have you here. We wanted to get a sense of what the funding models look like for virtual care in the different countries. We know that it's an expanding market, but the funding models are very different in each country. So it would be very helpful to have a bit of a sense of what the funding and financing from virtual care looks like in Indonesia, in Australia, and in Norway. So perhaps we could come to you, Annie.
Yes, thank you. So Indonesia is a country with a population more than 270 million people, and 95% already covered by BPJS Kesehatan as single payer system. So with the internet penetration of more than 78%, I think the virtual care is also among the opportunity for our country to support the challenges in Indonesian health system, mostly because of the maldistribution of the health facilities and also the need to cover people mostly in remote area that are not supported by available medical doctors. So there are several services that offer to populations. The government offer services through BPJS Kesehatan or the health insurance through apps called Mobile JKN that offer for primary care consultation, direct to consumer consultation from member of health insurance to primary care. And the payment model is covered through capitation scheme under the health insurance. But for the referral or the hospital to hospital teleconsultation, it is supported by the government through the national budget and also the local government budget, especially between hospital, district hospital, when they consult to the vertical hospital or the Ministry of Health hospital. For the direct to consumer consultation that mostly provided by private sector like health tech or app, the government also developed a regulatory sandbox in which we develop a standard to ensure the safety, quality, and also the business model for startup to offer telehealth consultation. There were 14 startups that already involved in the telehealth regulatory sandbox. And currently, after the regulatory sandbox, the government is trying to develop the regulation specifically for direct-to-consumer teleconsultation. Among the issue that currently we are trying to solve is how to cover telehealth consultation under the health insurance. Currently, all the scheme like capitation is limited, and also the services in the hospital not under the health insurance claim for hospital, and also several services like home care, for example, or telerehabilitation. It is also beyond the current scheme on the health insurance. So I think the government is trying to develop this kind of hybrid model in which after we have the universal health coverage and we achieve this as part of the SDGs, we still have a problem or challenges and need to learn from other countries on covering the inclusive and comprehensive virtual care to be covered by health insurance. Thank you, Ilona and Dr. Sai.
Hey, thank you. Hey, again, sorry for joining a little late. Generally, I say, hey, we have to thank the gods of technology for all this to make it happen and give a little test for us today. Thank you to the attendees from around the world and our speakers and faculty from around the world. And thank you, Ilona, for spearheading this entire virtual care special interest group. So as you might have just heard, Indonesia, as you know, is a large country. And Anis, I think I'm right when I say, maybe you mentioned this, but your breadth across is maybe 8,000 kilometers. And you have like 17,000 islands plus. So you're very distributed out, and 200 plus million people. Having to connect to all of this is one, a logistical challenge. And second, I think, is obviously a funding issue, because you're going to need to replicate so many things in terms of the connectivity piece of it. So thank you for giving this great overview. We'll jump back in, Anis, into a little bit more detail, and we might ask you to put that slide back up. But I'm going to request now from Norway, Dr. Smeland, to give us a little overview of what he does. He's an oncologist, as you all might have heard, and it'll be very interesting to hear from his very early in the morning share of thoughts, how things are happening up in Scandinavia. Dr. Smeland?
Yes, good morning. Thank you. Okay, that is just an overview of the Norwegian healthcare system, and the same as in Indonesia, it's a one-payer system, single-payer system, and that is the Ministry of Health and Care Services. That is, we have the same system in all the Nordic country, and that is that the ministry, they are responsible for specialized healthcare to the population, and also they own the hospitals. And then Norway is split in 4 health regions. The blue part is the southeast region where Oslo is, and we have 1 referral hospital for each health trust. And Oslo University Hospital is a referral hospital for the southeast region. And compared to some of the other countries like Indonesia, India, etc., where it's not more than 5.6 million inhabitants in Norway, and about a bit more than 50% is in the southeast region. So that is the way we are organized. If we then go to the next slide, what we have done, program for virtual care. The first is about video consultation that opened during the pandemic. I think that is also an experience we all share, that then we were allowed actually to use the technology available. So today in Oslo, I looked at the numbers, so it's 9% of all outpatients consultations are video consultations. And those are reimbursed as the same way as for a physical or on-site consultation. So that, and of course, the patient will not pay for that part. So that is in a way it's sold, but it's of course in a way limited for the use. The good part is also for Norway that we are fairly distributed the population, and it's a lot of remote areas, so that is something, but I think it's about 10%. I think that is a balance, that the level we have today. So the next level is what I call the digital consultation, and for instance, digital prompts. And that is an example to the right. It's a program that we opened last year for prostate cancer patient that has the curative radiotherapy, either single or in combination with surgery. And we had that, it should be 2024, 600 patients last year. That is different. That is for the different areas in medicine, definitely not only oncology. And I state here we find what is reimbursement in development. We don't see the patient. Today, the technology is that they fill out a standardized questionnaire like this EPIC 26. For those of you who know the field, that is a internationally validated questionnaire that is in use for prostate cancer patients all over the world, actually. So the reimbursement is not per patient; it's per patient, not per consultation. That means that if you have 600 patients, then you have a pay per 600, whether you have 1 consultation or 10 consultations during the year, it will be the same. So that is something that the Ministry of Health is working on, that part, actually. So because what is important for that part is you address the part with the remote population, the challenge, but also the need for consultation in total. It's not that you have a digital consultation that replace on-site consultation, but also we will reduce the number of consultation, and we find that the number of consultation will go down 1/3 or something, and possibly even more, because when the patient replied to this questionnaire, if we don't find anything on that part, and if the patient don't need a physical consultation, there will be no consultation. So that is an extremely important part of that program. That is, in total, it will be a reduced number of consultations. The third part that we are working on is remote monitoring, and I think the fourth part is also important, is a combination. And what is the number one that I have not mentioned, that is hospital at home, that is not virtual, because then we send people out to the patient. But a combination with a hospital at home, with any of the others, that is something that we are working on in the total concepts these days. And that definitely add value to the hospital at home concept. Yes.
Perfect. Thank you so much, Dr. Smealand. It's a very nice overview, and it's fairly well demarcated, and looks like quite interesting. And we'll get back into this too later today. And of course, towards the end of the day in Australia already, Dr. Robert Marshall, who's a CSO for St. Vincent's, could you please share some thoughts on how Australia is coming up in this space?
Thanks, Dr. Sai. Yes, we'll do. So, quick bit of Australian context. I mean, as colleagues have said, that we saw massive, rapid adoption of virtual care models during the COVID pandemic. Actually, pre-COVID, the proportion of Medicare services, which is our public-funded primary care model, was as low as 0.05%. So it really wasn't a modality that was widely used in the years before COVID. And we saw that surge up to 36% of all consultations during COVID. So clearly, the necessity of that did drive adoption. It was helped by government funding. So primary care is very itemised in Australia in terms of how it's funded. The government created new item numbers or allowed for telehealth to be used for existing item numbers. And so there was really a massive adoption that we did see that come down and plateaued more or less at around 23% by 2022. I think what's interesting, maybe in the Australian context, is we did see a lot of telephone adoption of those sorts of consultations. So even though there was quite a concerted push to use video conferencing and video modalities. Actually, it's turned out that quite a bit could be resolved by just speaking over the phone. And I think, you know, you can see there that electronic mail messaging is still very low. So we have, because we don't have a, you know, we've got a very federated system. Every state has a slightly different approach to hospital management. Primary care is very much run as a even though it's funded by a single payer through the government, it's run as a sort of small business model with lots and lots of different approaches to that. There hasn't traditionally been a unified messaging platform. There has been a more concerted effort to invest behind that with a shared, you know, patient record, patient platform, but that's yet to be really fully utilised for things like messaging and asynchronous consultation. In terms of the hospital side of things and virtual care as an enabler of admissions, we've seen the proportion of all admissions that are done as hospital in the home with some element of virtual care hover at about 5%. Of course, the focus of that is really on either what kind of think about as the tail end of care. So people that are, you know, have had some procedure or something in hospital and are kind of getting better but still sick, going home a bit earlier is still the main use case. And then, of course, specific DRGs, you know, conditions where they can be identified early and are pretty clear cut and just require things like antibiotics or wound dressings. We do have relatively mature pathways for getting those sorts of patients out of emergency departments and into home. I'd say there's still a long way to go, but a lot of movement that's happening very fast in what would be more acute care at home and genuinely disrupting the kind of hospital model. And that's, I mean, that's also happening, I think, in primary care. The government has locked in a lot of the COVID era funding mechanisms for primary care telehealth consultation, which is good. But there's now sort of, I guess, emerging competition, emerging players in that market. So we have direct-to-consumer platforms, as you would have in other countries, offering sort of single drug, single service products, particularly for the sorts of things that people don't, you know, always like going to a doctor to get in person. So prescription, reproductive health, medications and hair loss, you know, medications and those sorts of one-off things, obesity drugs like the new GLP-1 agonists, etc. So there is an emerging model for telehealth consultation as part of that direct-to-consumer offering. We're also seeing private insurers move more into the space and offer things that help navigate or manage people to stay healthier and prevent hospital admissions, particularly with chronic conditions. And then I'd say just overall, in terms of the Australian context, we have a universal health coverage public system, but we do have a mature private hospital system that's largely focused on elective surgical procedures. There is an emerging model now, but because of the pressure of costs and inflation and medical costs in general going up, to shift more of the care that would have traditionally been a sort of longer stay in hospital to home. And again, Australia is probably a little bit behind the US, but otherwise in the middle of the pack for those sorts of length of stay advantages that you can get from virtual and at-home care. So that's a quick snapshot of where Australia is up to, but there's a lot happening in this space. It's moving pretty quickly.
That's great. Thank you so much. I think it's a good overview we've had from several locations. I didn't get the chance to introduce myself. I'm Sai Harnath. I'm a lung and critical care doctor. I do virtual critical care from India for the US as well as for India. Apollo Hospitals, as you might know, is a large hospital system, about 10,000 beds, 75 hospitals, and a lot of virtual care going on. And we partner with the IHF in really promoting the concept of virtual care because we feel it's a great solution for access. It's a great solution for equity, but this webinar really is designed to see how can we get it to be funded in a more robust manner, in a more consistent manner. And what you've heard is there are multiple models. There are folks who are doing it in terms of a government-funded model. There's a private model. And also, interestingly, in Australia, there are a variety of small business type models, so which is all very interesting. And I think it's good that we have this robust mix of ways of taking care of it because the needs are different in different locations. And also the health systems are sometimes not as advanced or do not have the technology that's required for some of these things. However, I think with the burden coming up it's ultimately the patients who have to pay for it, and the tech will keep getting cheaper and cheaper and more accessible. So I'm going to jump right into a few questions. We are just a short little bit running late, but I think what I would suggest attendees who have questions is to kindly put them in the chat, and we'll try to get to them for sure. And if you're just curious where the attendees are from, the participants, just put in a country and hospital system. If you want to share that, please put it in the chat. So I think I'm going to ask Anis this question, and a request to all the panelists to keep their answers relatively brief so we can run through all the themes that we need to touch on. How do you think the current ecosystem can manage in terms of there's a government system, there's a private system, but what do you think is the partnership that's required? Are there any incentives or disincentives that are already built into the current funding models? Anis first, and then Dr. Smealan, and then Robert. Essentially, what are the ways that the funding models are going to make things better or worse for us? Anis, from your perspective?
Yeah, thank you, Dr. Sai. I think for the incentive part, we know that the BPJS Kesehatan or the National Health Insurance give I think incentive and disincentive combined into the capitation scheme for the primary care services. They calculated the contact rate of the member of the health insurance in the primary care setting. If the member also consulted through the mobile JKN app, it is also counted as the contact rate. And the contact rate are calculated as part of the performance-based capitation scheme. So if they have a limited patient come to the health facilities, but it is also covered by those consulted through mobile JKN app, it will bring them the steady or capitation scheme because if they could also manage the capitation scheme also through the number of contact rate through mobile JKN, it is expected that they also involve the member of JKM for health promotion activities. So I think this is part of the incentive for the primary care setting. But for the referral setting, it is not provided by the government, either through the health insurance or other program. But as we know, for the startup, actually they receive support for the incentive by joining the regulatory sandbox, in which the business model will be covered and then included in our upcoming regulation. But it is not a specific incentive for the business itself, but for the recognition. Other aspect that all startup that already covered in or joining the regulatory sandbox are also offered to join several programs. For example, vaccination, or right now, free health screening program. They are also included into this government program. So the incentive for the startup, not for the business itself, but to join several the health program. Over, Dr. Sai.
So that's great, Anis. Thank you very much for that nice summary, and thanks, Alona, for pointing it out. I think it'll be interesting to know how the federated model is going to be replicable in other geographies. I'm just not sure if that same model might apply. So let's hear from Dr. Smealan, actually. Dr. Smealan, what do you think is an incentive and disincentive in your location for virtual care?
I think that the important part is about the digital consultation, and we have, as also Robert said, that is emerging technologies. So the field will change. Today, we don't have the economic incentives actually to take that journey. So that is a big challenge, and that is something about what we will. It's not only that it's obvious it's good for the patient. Actually, they don't need to travel, but the other part is that what we hope to do with those programs is that to have a reduced activity. Today, we find that, for instance, follow-up of cancer patients after successful treatment, we use too much time on that part, actually. So, as I said, if we will, this example, the follow-up program for prostate cancer patient, we can reduce the number of consultations with 1/3, even 2/3 or whatever. You don't find an economic model actually for that part, and that is a challenge because for Norway and I think other countries, the shortage of the workforce, that is I think it's the biggest problem, especially in nurses, but also doctors and others. So that is a challenge. So if we can reduce
So, Dr. Smealan, if I might just interject really quick there. So what I'm trying to understand is, so there's a patient with a cancer, he gets chemotherapy, he needs follow-up afterwards. There is no incentive for him to stay at home and get care. He would rather come to the hospital or the clinic as many times as needed. Would that be correct?
No, if for the patient, I think the digital consultation, it's a good solution, and the compliance for the patient, it's excellent. It's I think the questionnaire is close to 90% of this of the patient. That is something about also the maturation, the digital maturation in the population. Those are men above 70, most of them. But if you look at the hospital part, there is today with today's system is a financial risk actually. So the income for the division, that will be reduced because we don't have per consultation payment as is today. So we have, that has to be changed, and the ministry is working on that part, and they have to work on that part. It's not only to work; they have to find a solution, and that is my point. That is, we should have in some way payment to have a follow-up program for a cancer patient, not per consultation. It should be the content, not the activity per se. If you understand me, if you can change that, then, because today I will say that it's a lot that for that part it's unnecessary. I just have an example, if I may, that was from Princess Margaret in Toronto, and that was comparable population. That was low-risk breast cancer patient that were followed up for 10 years after primary treatment, and they have excellent prognosis. And what I found that they needed 35,000 consultations to find 2 relapses. That is, we cannot use the doctor time, the nursing time on that part. So we had to do it in a more efficient way, and I think that is the digital
I agree
consultation.
with you. No, I think that's what you've said so far, Dr. Smealan, is a very good point, that even though it's great for patients and the system is actually paying more to get them in, there has been no incentive to change it. Which
Exactly,
to us, as people in the front line, it's like, why is it that way? So I'm going to actually put Robert a little bit on the spot and say, hey, Robert, you know that this is great stuff. We know that these things work everywhere. Why have we not adopted more? What incentive is missing that is not allowing us to do virtual care more robustly? And I'm going to ask you also, because I know you love technology, what is AI going to do to this whole ecosystem? I know we haven't talked about AI so far, but I'm going to give you like a couple minutes because there's a whole bunch of other things to get through. So Robert, your thoughts on these 2 themes?
Well, I mean, briefly, I think when we started with funding, that is clearly still getting in the way. Even though we have some of the incentives that I mentioned that are good, that are positive, specific item numbers for virtual care consultations. If a public hospital sends someone home on HIF, they do get paid through the activity-based funding model. But really, it's still largely an activity-based or fee-for-service model. It's just, it's just a bit more sophisticated than that in Australia. And clearly, to do proper virtual care, particularly the sort of end-to-end journey version of it, where you start earlier and you avoid a hospital admission altogether, or you help someone manage their chronic condition in the community. We need a funding model that can take account of the cost that you've avoided, but of course no one wants to pay for that because they're hard to prove and capture after the fact. So I mean, these new funding mechanisms have been talked about for some time. We've had a few small experiments in Australia, but clearly some form of a bundled payment where you incentivize providers to take end-to-end ownership of the patient navigate them to the lowest possible cost care setting, it has to be part of the solution. To do that, though, you do need other things. So I think traditionally, I think the workforce has been somewhat resistant or reluctant to these kinds of models, in the sense that you know if you have the patient in front of you and you can duck down to the ward and see them, that you can have a quick intervention, check on the wound dressing, etc. I do think COVID it was the crisis that we needed to show that actually we can be a bit more, not relaxed, but we can have a bit more of a team approach to that kind of care, that actually you can trust other clinicians to take over bits of the care across that care journey. But I do think there's still a way to go with those models. But we definitely see increasingly actually our clinicians are really up for the challenge of working in different ways and these kinds of virtual models. And then the third element, so funding, workforce, I think that third element is really the technology, which also has a funding aspect to it as well. Clearly, it's never been easier to build these platforms. The tools are available, remote patient monitoring, being able to asynchronously manage and monitor lots of patients. That was what people dreamed of in virtual care a decade ago. That's now all possible. But it still has to actually be accounted for in the funding. And I think we're in a bit of a transition period where perhaps insurers in particular in Australia want traditional hospital providers to shift quickly to these at-home and virtual models. But of course, you've got to fund the uplift that's required in technology. There's a lot of investment required in things like cybersecurity. When you start to shift patients and use their devices, etc., it's not all locked down like a hospital model. So there's a lot of sort of embedded costs with that I think funders, both governments and insurers and patients themselves for out-of-pocket models have to help support. Just briefly on AI, I'd say clearly it presents a big opportunity to us to bring together disparate data sources. That's still a major disincentive in Australia, that the way the care gets delivered is mostly dependent on the funding pipeline. And what you really want is some way to mix and blend different payments and, again, take end-to-end ownership of the patient. I guess the good news on the technology side is AI perhaps allows us to bring together disparate data and make sense of it in ways that we haven't before, including being able to query and question things with plain English or native natural language models. And I think that's a really, really positive development that, again, once we do make the investments, will really accelerate adoption of that kind of asynchronous patient monitoring.
Perfect, great. So I think that's good answers and very good insights. Thank you. We're running a little short on time. I know there's a lot to get through, so I'm going to actually start directing one or two questions here. So Anis, this is for you. You know that equity and access is a big challenge. We know that. And we know that a lot of people get left behind. We really don't know who decides who gets left behind in the virtual care delivery paradigm. So if you were to think about the government system, and in Indonesia, you mentioned that the private ecosystem is also getting in, how do you ensure that the two systems interact? And also, how does that determine the pricing and the quality? Can you comment on these two aspects? How does clinical quality get safeguarded so that both systems are at a certain level? And also, how do you ensure that the pricing of each of these models interact with each other? Any thoughts on that?
Okay, I will start with the second question first, related to the tariff or the price for the consultation. So currently, given the public and private, even for the for the public, like what I mentioned to you related to the teleconsultation scheme for hospital to hospital teleconsultation, it is developed by the government. Tariff was developed by the government, and also government based on the agreement by local government. So local government, given that several districts have a different fiscal capacity, those in remote area could sometimes also pay for the tariff of consultation lower to those in the urban area. But it is agreed by the collegium or the consortium. The consortium, like the Collegium of the Obstetric Gynecologists for Tele-USG, Collegium of the Cardiology, they agree as long as there is MOU between national government or the Ministry of Health with the local government based on the different tariff. So I think in terms of tariff, it is the role of the government to set up this tariff because the fiscal capacity of every district are different. But in Indonesia, we do not have a standard tariff for doctor nationally. So it is also the among the role of the government to set up on this aspect. On the second part, related to how
Anis, really quick,
between
what would
the
be an average cost of a visit, a virtual visit? Say a general medicine
for the
diabetes checkup.
for the teleconsultation under the government scheme, it is started from the 50,000 rupiah to 150,000 rupiah. 150,000 is about 10 US dollar. 50,000 is 3 US dollar. It is for the clinical teleconsultation, tele-USG or teleradiology, but for only one side teleconsultation.
So
But it
I'm
is
just
developed by the
asking that
government.
because I don't think Dr. Smealan and Robert, could you ever do a consult for $3 to $5 in your environments?
Probably not.
So I think the point I'm getting to is we probably need to figure out a way to have cross-border care so the prices get
Yeah.
subsidized and lowered, similar to the airline
Yeah.
industry. And sorry, I'm interrupting here, but if you look at the airline industry, tickets across the world are more or less the same. I mean, if you fly a certain distance, that's the price.
Yeah.
Airlines are using technology, they're using a lot of automatic information to fly all the time. And they're way ahead of us, and we all trust them. The finance industry, we trust them in general. So I think healthcare needs to take some lessons from some of these more mature industries and really start acting. And a lot of it is, I think,
Agree.
caregiver trust, caregiver control of the health ecosystem probably is very big. And that's a human factor. And I'm not saying it's all going to get fixed, but we should probably move in the direction. Sorry, Anis. Back to the other question about the quality piece. And then you have only 30 seconds
so
to that. We need to get through a few more things.
Yeah. So in terms of the quality, it is also something that Indonesia need to learn from other countries, from Australia, also from Sweden, because right now the collegium, the medical doctor collegium, did not set up the standard of quality on virtual care. It is different for the physical care. We have also the standard, but for the virtual care, we do not have the standard. So actually, we learn from the regulatory sandbox in which the private startup started to develop the standard for the virtual care. So I think it is on the way that Indonesia needs to develop this kind of the standard for the quality care and safeguarding the services to the population. Over to you, Dr. Sai.
Perfect. Thank you so much. So we were going to have more input, but I do want to give at least 5 minutes for the audience. I'm going to run to the next little bit. I think we need to look at the way forward. What is the next way forward? And I'm going to request Dr. Smealan to think outside Norway a little bit and say, using your experience as a frontline clinician, dealing with people who are at the ends of their lives, as well as in a very complex, stressful part of their life, how do you think virtual care can assist from a global aspect? And how do you think that can get funded? Do you think patients will be ready to pay out of pocket for high quality virtual care from anywhere, as long as they get their questions answered, a mechanism for their pain to be taken care of, and understand what their symptoms are? Would you think patients are ready for that kind of a model?
Definitely, I think so. What I think it's not only about the patient and the hospital, but it's also the structure between hospitals. That is a key topic in oncology these days, and that is about the Comprehensive Cancer Center and the Comprehensive Cancer Center networks, actually. And we are working on that even in Norway, but that can be extended at the European level or globally. That is that you have, so to say, a hub, and then you have a virtual meeting, and then the decisions it's like an MDT meeting. It's with all the expert, but the treatment and the follow-up of the patient is at the local hospital. And that is a long distance, even as a country like Norway, and I can imagine in Indonesia, etc., etc. So I think that with all the opportunity we have, this virtual care concept will also that we can, as top expert, we can reach out to either to the patient but also to the colleagues actually. So the patient don't need to travel. That I think
That's a great answer. And I think Ilona knows this. I think every webinar we try to get one action point that we can act on. So I'm going to say after this webinar, I'm going to request Dr. Smealand, Robert, and Anis to find champions for this model where we can perhaps collaborate and come up with a way to set up an MDT and set up a mechanism to interact, perhaps pick a patient, and let's chat after the webinar. And folks on the attendee list, if you would like to participate, please shoot an email to Ilona or put your name in the chat, and we can perhaps come up with a mechanism to at least discuss how to do this. Great. Now, we've kind of talked about funding models. We've talked about government systems, private systems. We've also talked about patients wanting this. We all know the value of this. And I would want to ask Robert this question. Australia is a big country, perhaps what, second largest in the world, a third, I forget. But why do you think we have not seen uptake in the cross-country, I would say, virtual care, especially for the native population? Or is that already happening? I haven't heard that much. I would think it's because we've heard of the Australian bush pilots, flying across, and that's a huge, the bush service is a big service. Do you think that's something that's going to happen in the near future as something that's going to change with the coming times, along with the change in the funding model, Robert?
Yeah, I mean, I think it's one of the more obvious use cases for great virtual care is to reach into communities that live very far from cities with hospitals. Actually, there has been a reasonable amount of innovation in that space. It sort of flies a bit under the radar. But it also happens because of the funding. It happens very much state by state, region by region. There isn't a connected universal model for that. But in the Northern Territory where I've worked, there are patients, thousands of kilometres from hospital that can, connect in virtually, or the nurse sitting next to them can connect into a model straight to the emergency department in the tertiary centre. And then, of course, if you need to escalate, yes, you're left with a Royal Flying Doctor sort of service or sort of medical retrieval. I think, it's okay to have patchwork innovation and everyone has their own model. I do think we're coming to a moment where if we want to solve these problems seriously, to your point about cross-border collaboration, I mean, we have borders within our own country, as everyone on the call will have. We've got to solve that, have at least a national, to begin with, view on what is the kind of base, quality standards have been talked about, but it's also what's the base kind of technology. And that doesn't mean everyone has to do the same thing, but are we moving in the same direction, more or less? But actually, there is innovation there. It's perhaps just not been scaled.
Got it. That's good to know, Robert. Thank you. So now we all know that the environment is something we need to protect, and to me, there is some data suggesting that virtual care does prevent patient visits to hospitals when it's not needed. There have been we have done ourselves a little study of what is the fossil fuel usage, how much money a patient's spending when they come from a rural area to an urban center. Because, say, for example, in India, not just the patient, but the entire family comes along. And then oftentimes they lose time from work, they lose time from school and income. So there's a lot of secondary costs to all of this. And I think it's important to focus on the benefits to the entire family, not just the patient. And I'm going to, in the interest of inviting some questions from the audience, I'm going to ask the panelists, if you were to think of the path forward, can you share what is your ideal funding model? What do you think your own environment should do to make this doable in 6 months, a year, and 5 years? You have a minute each. So we'll start with Anis. Timer starts.
Yes, I think Indonesia need to develop a clear and fair reimbursement rates under the National Health Insurance Scheme for any types of telehealth, including those that are not developed yet, for example, on the follow-up care and remote monitoring. Secondly, we need also to develop a national standard of clinical quality and data security. And also we need to develop the regulatory and licensing framework, especially for many Indonesian having consultation in neighboring countries like Malaysia and Singapore. I think this is also some aspect of regulation we need also to develop. Over to you, Dr. Sai.
Dr. Sai, you're on mute.
Thank you. What would be your ideal, Robert, in terms of a funding model that makes sense and is scalable and solves the problem?
I think it's actually giving the providers the autonomy and the permission to blend funding. So we're working now on some very targeted segments with kind of product mindset of designing like a true model of care that does acute care at home and virtual care and chronic condition management. I'd say actually what we want from payers is to decide what's fair as an envelope of care, and then let us sort of innovate within that boundary. So basically a blended bundle kind of model would be ideal from a funding point of view. Yeah, that would get us going, I think.
Great, thank you. And Dr. Smealan?
The challenge today is mainly on this digital consultation, the teleconsultation, that is the same system that we have for standard consultation. So they had to work on that part actually, and they also have some incentives actually to have the technology available also. So we need some specific funding for the technologies. So if that will be available, that will be a huge step forward.
Got it. Great. So just to summarize, we've heard about the need for blended funding models. We heard about the need for standardized models from institutions of, say, government. We've also talked about the role of technology. We also learned that there is a need from the consumer/patient, but systems need to adapt faster because they are not serving what they need. In fact, they might save money and get more resources if they really thought about this. And I think from what we've also heard earlier on, there are clear benefits to virtual care in all aspects. There is better care, patients like it. Now, of course, COVID, there was as Robert showed in his slide, there was a peak during COVID and it dropped off, which is a uniform phenomenon seen everywhere. Now, there have been discussions on why that's happening. Some people talk about the fact that of convenience of sorting out problems faster. They talk about the trust factor. But I don't know. I don't think we have the real answer. See, when I do virtual critical care from India for the United States, I'm taking care of people who are critically ill, and I'm able to solve a lot of problems remotely. And my mind says that with even more better technology, with AI doing auto diagnosis of things, with a co-pilot that can help you with differential diagnosis, there's a lot that can be done. So I think we have a pretty good broad discussion. Obviously we didn't solve the problems. We did get one outcome that we should talk about, setting up a virtual MDT with our institutions together, which I think Ilona will help us kind of action on. Audience, anybody from around the world who's joined in would like to say something?
Dr. Sai, we did have a question in from India around commonly used quality metrics for virtual care models, which is extremely well timed because actually our next conversation in virtual care will be looking at building trust around virtual care and how to ensure quality and patient safety. So that will be on September the 2nd. So we'll make sure everyone gets an invite for that. So I think we'll cover that question in our next conversation.
Absolutely. And I think, the reality is virtual care is care too. It's not different. It's care. What are the extra things we need to do for virtual care to maintain those standards? Because there's going to be a lot of things around consent, a lot of things around accuracy, a lot of things about triaging. You've all seen those patients who are not right for virtual care, right? So it's a convenience, but they clearly need to be in a hospital. I've had patients with COPD in a very bad flare-up who were too tired to go to the hospital, decided to do a virtual care consult, but I'm very quickly telling them, I'm calling an ambulance for you. So we need to be able to do those things. And if there's no questions, we can continue chatting for a couple of minutes. The tech piece is very interesting. I know companies who are out there, who have for many decades now, have devices where you can listen to the heart, you can listen to the lungs, you can examine the fundus. Now there are companies doing photoplethysmography, which is where you can pick up heart rates, oxygen saturation, blood pressure virtually through camera. then there are devices and AI that can actually have an interaction with the patient and the provider to get information about the patient's symptoms and give a differential diagnosis. And these places are, rapidly really advancing. You also have camera-based analysis. So if somebody puts in their report, and even if it's handwritten, the AI can take a picture and then give you an insight as to what's happening. So I think those, I believe, are things that are already available, which will continue to come through. And if there's no questions on the chat, I'm going to request Anis, if you have any other comments you'd like to add, and then Dr. Smealand, and then Robert.
Yeah, related to the advanced technologies, after we learn from the experiences on the regulatory sandbox, we know as well that several countries, including, for example, in Europe, after the EU Act, they also requested every country to implement sandbox for AI. So we expect that new AI technologies, either for low risk and high risk AI technologies, especially in healthcare. We expect to continue the previous model on regulatory sandbox because technologies runs very fast and regulatory is always late behind. And usually when regulatory late behind, the aspect of the fee or the tariff also late behind. So if the fee and tariff not settled, so it will suffer the doctors, it will suffer also the patient. So I think it is also a step that when we learn new technologies, regulatory should also work fast and also to learn from the technologies and then adopt the technologies. So I think even though the experience of regulatory sandbox for new technologies, I think not very rapid in Indonesia, only for the financial and health sector. But I think it is also a good start when AI technologies, all new advancing technologies come into health sector. Over to you, Dr. Sir.
Thank you, Anis. Dr. Smealand, any interesting comments you might want to make about
I will just,
next?
one aspect is that our experience so far is that the technology maturity in the population and also in the elder patients, that is high. So it's not a problem actually with today's technology availability access. So the compliance to the systems, different solutions are excellent and very high. So that is, I think it's very important. The other aspect is that what's probably the next seminar is that with the use of this new system and this questionnaire, etc., the standardized report, it's much better than what we used to do during the consultations actually. So we will have standardized report. It's an excellent opportunity for secondary use of data, and that will increase the quality and we increase our knowledge. So I think we have some strong opportunities with this new technology beyond what we see today. I have a next meeting at 9 o'clock, so sorry, I had to leave this meeting.
Perfect, great. Thank you so much all for joining in. And I'm just going to, one final thought would be, what if somebody else paid for it? So I know of systems where there is free care, where there's philanthropic organizations, charities who are actually taking care of the cost of virtual care. And there are many non-governmental organizations who actually do this. Many governments do it for free. So I think the cost is an artificial thing in my mind. The intent as well as the utility is something we need to really showcase more, because clearly patients will benefit. So thank you all again. Thank you, Dr. Robert Marshall, Dr. Anis Fouad, and Dr. Smealand for joining in. Ilona, thank you very much again for coordinating as always. And look forward to joining you all in the next webinar in about a couple of months or so in September.
September the 2nd.
September 2nd, great. And November, of course, is the annual conference in Geneva, where we're going to have a very interesting set of programs from the Virtual Care Special Interest Group. And again, I thank the organizers of the IHF, because a lot of people in the back end who are helping put these things together. And of course, my hospital system, Apollo Hospitals, is very glad and eager to continue to participate and support the IHF in these endeavors.